Hi everyone, this is Susan Panter. Today I am talking about alterations in cardiac output and tissue perfusion, and in specific we're going to look at the concepts of perfusion and how it relates to cardiac issues. This is for your 2244 nursing course. A couple fun facts. To survive, all cells need a constant supply of rich blood. When blood supply or perfusion is impaired, ischemia develops. This can progress to necrosis or tissue death. So with tissue perfusion, we have the flow of blood through arteries and capillaries, delivering nutrients and oxygen to cells, and also we have to remember that we have the removal of cellular waste products. So our scope of perfusion includes optimal perfusion, impaired perfusion, or no perfusion at all. With optimal perfusion, we have cardiovascular health. With impaired perfusion, we have ischemia that occurs. And with no perfusion, we have tissue death or infarction that will occur. So perfusion at its finest, we have to remember we have both central and peripheral perfusion. In central, we have mechanisms for blood delivery. It's generated by our cardiac output, and it does propel blood to all of the organs and tissues. If we look at our peripheral perfusion, we have a volume of blood that flows through the targeted tissues, and it's supplied by blood flowing from the patent arteries to capillaries surrounded by smooth muscles. Our central perfusion and our peripheral perfusion must work together as a team. The force of the ventricles contractions creates hydrostatic pressure, which pushes blood through capillaries into the interstitial spaces, allowing delivery of oxygen, fluid, and nutrients to all of our cells. When one is affected, the other is affected. Significant reduction of central perfusion results in shock, which occurs when blood supply to tissue is impaired because of inadequate cardiac output. Significant blood loss or vasodilation through the body. When one loses, the other loses. We need to remember that adequate perfusion is required for life. So we do have risk factors that are contributing to cardiovascular disease or perfusion problems. Non-modifiable include age, gender, family history, and race. We do know that the older you are, the higher at risk you are. Males are a little bit higher at risk, and also African Americans become a little bit higher at risk. As far as modifiable risk factors, we have smoking, which leads to vasoconstriction, hyperlipidemia, which can also lead to atherosclerosis. Sedentary lifestyle will lead to obesity. Obesity can lead to diabetes and atherosclerosis, also putting an increased workload on the heart. Diabetes can lead to atherosclerosis and peripheral vascular disease. And hypertension can lead to an increased workload on the heart. Impaired central perfusion occurs in conditions that decrease cardiac output, such as any occlusion or constriction of the coronary arteries that reduces the blood flow to the myocardium, that can result in myocardial infarction. This impairs the myocardial pump action and the effectiveness of how our heart pumps. Another way is alteration in impulse conduction being interrupted by electrical functioning necessary for contractions. And the third way is malfunction of the heart valves, which impairs blood flow through the heart. So what are some of the consequences of impaired tissue perfusion? This is our pathophysiology, or the things that are happening in the body that are not normal. So ischemia can occur because of a demand for oxygen that exceeds the supply due to decreased or cessation of blood flow, and cellular death can occur if the blood flow is not corrected. We also see a decreased oxygen to the cell mitochondria, which reduces ATP or adenosine triphosphate production. Three things can happen here. We can have lactic acid buildup that causes cellular acidosis, destruction of tissue release enzyme or creatinine kinase, known as CK, and then also measurement indicates the degree or damage of the heart muscle. With a lack of ATP comes the inability to maintain the adenosine triphosphate pumps, sodium and potassium pump, in other words, which uses energy provided by ATP to pump sodium out of the cell and allow potassium into the cell. Potassium deficit in the cell can cause dysrhythmias. Sodium excess in the cell causes swelling and increased membrane permeability. And the increased membrane permeability causes calcium to enter the cell, where they activate lipase and protease and increase production of free radicals. And the free radicals, in essence, damage our healthy cells. We have cell damage that initiates the inflammatory response. When ischemia persists, irreversible cell injury or cell death occurs from necrosis. So some of the issues associated with decreased perfusion that we're going to mention can be from decreased cardiac output disorder, myocardial infarction, or cardiogenic shock. Can also be from electrical conduction disorders. We would see dysrhythmias and maybe even life-threatening dysrhythmias. And the other is hematological disorders, in specific DIC, hemolytic anemia, and leukemia. The other thing I just want to remind you is that there are some other issues that are related to perfusion that can also affect cardiac output, being congestive heart failure, pulmonary edema, and cardiomyopathy. So let's talk about myocardial infarction, known as acute myocardial infarction, or MI. This is an ischemic necrosis of a portion of the myocardium, or the heart muscle, which is produced by an abrupt decrease in coronary blood supply with deprivation of oxygen to the tissues. Sometimes you see an ST elevation on your EKG reading, which is known as a STEMI, or you can see non-elevated ST segments on your EKG. So the extent of tissue damage depends on three things: the size of the blood vessel, the location of the blood vessel, and the reduction of the blood supply. So is it reversible or irreversible? That is the question. So remember, ischemia is reversible. All we have to do is give oxygen to that tissue and that tissue will be revitalized. Whereas in infarction, that is irreversible. The tissue has died. It's gone too long without oxygen supply and was unable to maintain its viability. So what is shock? It is the inability of central perfusion to supply blood to peripheral tissues. Shock occurs when the heart is unable to act as a pump. That's known as cardiogenic shock. Fluid is lost, known as hypovolemic shock. Systemic vasodilation occurs, which, if it's from allergies, it's known as anaphylactic shock. If it's from neurological injuries, it's known as neurogenic shock. Or if it's from a severe infection, it would be called septic shock. In cardiogenic shock, we have an unhealthy heart muscle, we have pump failure, and decreased perfusion. Signs and symptoms of cardiogenic shock: tachycardia, hypotension, a systolic blood pressure less than 90 millimeters of mercury or less than 30 of the patient's baseline, urine output less than 0.5 to 1 milliliter per kilogram per hour, skin that's cold and clammy, decreased or absent peripheral pulses, level of consciousness changes, pulmonary congestion, tachypnea, and chest pain. Our treatment for cardiogenic shock include medication, oxygen, intubation of our patient, and mechanical ventilation, and an intra-aortic balloon pump. Some of the medications include morphine, diuretics, nitroglycerin, vasopressors, and positive inotropic drugs. So dysrhythmias or arrhythmias are abnormal rhythms of the heart's electrical system, which we looked at in our skills lab this past week. The ability of the heart to effectively pump oxygenated blood throughout the body may be compromised. Dysrhythmias are abnormal cardiac rhythms, which we can have too slow of a heartbeat, bradycardia, too fast of a heartbeat, tachycardia, atrial issues, the ones in particular that we kind of identified this week, atrial fib or atrial flutter, ventricular issues, which would be VFib or VTAC, and conduction issues are like our heart blocks. So dysrhythmias have many causes, or many different causes, I should say. Myocardial infarction is one of those. Electrolyte imbalances, especially potassium and magnesium. Hypoxia definitely can lead to dysrhythmias. Drug and alcohol toxicities, hypovolemia, even stress, fear, and anxiety, and sometimes the things we take into our bodies, such as caffeine and nicotine, can cause dysrhythmias. Now, our signs and symptoms of dysrhythmias are going to vary according to the specific dysrhythmia, but some of the main ones that we are just going to touch base on would be chest pain, level of consciousness changes, dizziness, syncope, palpitations, pulse changes, hypotension, dyspnea, tachypnea or orthopnea, lung and heart sound abnormalities, jugular vein distension, weakness or fatigue, pale, cool, diaphoretic skin, and nausea, vomiting. And again, the treatment of dysrhythmia is going to vary according to the rhythm or the dysrhythmia that we see on our EKG monitoring. Many times we will need CPR, various different medications, and things like pacemakers or cardioversions or defibrillation may be needed to correct the dysrhythmia. Disseminated intravascular coagulation, or DIC, is a condition in which small blood clots develop through the bloodstream, blocking small blood vessels. Widespread clotting depletes the platelets, and clotting factors needed to control the bleeding causes excessive bleeding, and we need to identify this as life-threatening for our patients. So some of the causes of DIC include cancer, sepsis, liver disease, intravascular hemolysis, prosthetic devices, and metabolic acidosis. Signs and symptoms include pain. You'll also see stroke-like symptoms, dyspnea, tachycardia, reduced kidney function, and even bowel necrosis. So management of DIC is prevention. Prevention would include practicing strict aseptic technique and also teaching signs and symptoms of infection. The other thing would be treatment with antibiotics, anticoagulants such as heparin, and clotting factors. Hemolytic anemia is a blood cell destroying anemia present in sickle cell disease, hypoxia, anoxia, ischemia, cell death, and organ failure that can all occur from that. Causes of hemolytic anemia include infection, exposure to temperature extremes, exercise, trauma, stress, exposure to high altitudes, and also exposure to alcohol and drugs. Signs and symptoms of hemolytic anemia present with dyspnea, fatigue and weakness, tachycardia, hypotension, heart murmurs, S3 sounds, jugular vein pulsations, variations in peripheral pulses, temperature, and also capillary refill, priapism, pallor, cyanosis and jaundice, oliguria or anuria, joint changes, especially pain and swelling, and also central nervous system changes such as hypoxia and again stroke-like symptoms. So we will manage hemolytic anemia with oxygen use, pain management, In particular, use of morphine or hydromorphone IV routinely to help control that. NSAIDs for inflammation, hydroxyurea, also hydration, improving that with fluids and oral fluids, and then complementary therapies, especially for discomfort. Leukemia is cancer with uncontrollable production of immature white blood cells known as blast cells in the bone. Bone marrow becomes overcrowded with these immature, non-functioning cells, and the production of normal blood cells significantly decreases. It can be acute or chronic, and it can also be lymphocytic or myelocytic. So why is leukemia so bad? Because we have cancer cells that lead to anemia, not enough oxygen, thrombocytopenia, bleeding problems, leukopenia, infection. So without treatment, we have death that can occur. Leukemia can be caused from genetic tendencies, or it can be from environmental, being around radiation, viral infections, or exposure to toxic chemicals and drugs. So if we look back at what I told you about anemia, thrombocytopenia, and leukopenia, you can see that our signs and symptoms of leukemia mirror that. So we have excessive bleeding with thrombocytopenia, weakness and fatigue with anemia, and fever and infection with leukopenia. Management of leukemia include prevention of infection, prevention of injury, and prevention of fatigue, which can lead to accidents also, or safety risks. So prevention of infection, we want to maintain infection control, monitor for signs and symptoms, and monitor white blood cell counts. Prevention of injury, we want to avoid contact sports and things that injury can occur from, monitor our clotting times, and then we also want to prevent our fatigue with alternating activity and rest and monitoring our hemoglobin levels. So interrelated concepts identified so far include perfusion, gaseous exchange, fluid and electrolytes, and acid-base imbalance. So if you think about how they are interrelated, without a good pumping action or blood flow, oxygen won't get to the cells, sodium and potassium won't exchange, acidosis occurs, cell death and shock will ultimately occur. Some of our history taking, subjective data will be diet, identifying a patient that's been on a high-fat, high-carbohydrate diet that can lead to atherosclerosis, exercise, a patient who is infrequently exercising, which again leads to obesity, smoking, because we know that nicotine causes vasoconstriction and leads to hypertension and increased workload on the heart, and also alcohol consumption, which is associated with some dysrhythmias. We want to ask about chronic diseases such as diabetes mellitus, renal failure, and hypertension. We want to ask a list of medications, how long they've been on medications, and how effective they have been. And also identify if there is any recreational or street drug use, because those are both associated with MI and strokes. Also look for physical signs of those, because sometimes they may not tell the whole truth. So we also want to take a good problem-based history, looking at pain, dyspnea, edema, dizziness, and fatigue. And the associated data with that would include our onset and duration. When did it occur? How long did it last? The location of the pain. Describe the pain and how severe is it on a scale of 0 to 10. What factors alleviate the symptoms, or what factors aggravated the symptom? Any other signs and symptoms associated with that, such as nausea and vomiting. And also we want to look at what action did they take to relieve the symptoms. So how do nurses perform a quick focused assessment on perfusion? Well, again, we need to look at our central perfusion, our cerebral perfusion, and our peripheral perfusion. We are going to identify central perfusion through our heart rate, our blood pressure, our cardiac output, cardiac index, and central venous pressure. Also, through our cerebral perfusion, our orientation status, our mentation. Do we have altered mental status? Do we have good bilateral movement and sensation of extremities? Our speech, is it clear or is it garbled? Carotid pulses, are they present? Are they strong? And then we're going to look at peripheral perfusion. What is our skin color? What is the temperature? Is it warm? Is it pink? Our radial pulses, especially our dorsalis pedis pulses, and radial pulses, because of the distal to the heart, we want to make sure that they are strong and that we don't feel any irregularities there. Also, we're looking at capillary refill. Findings associated with our central perfusion when we have issues that are dealing with that particular body system will be vital sign changes such as hypotension, tachycardia, orthostatic hypotension, seeing a drop in blood pressure when our patient rises. Along with S1 and S2 sounds, we may hear S3, S4 sounds, heart murmurs, of course, dysrhythmias, changes in our level of consciousness and orientation, and also shortness of breath. Findings associated with our peripheral perfusion issues would include diminished or absent pulses, decreased amount of hair on the legs, cool, pale skin, decreased capillary refill, and edema. And sometimes you may even notice a discoloration of the peripheral skin tone. So one of the important things for a nurse is to have priority nursing actions ready for any client that has alterations in cardiac output and tissue perfusion, because we want to make sure that we are preventing life-threatening problems. So we're going to observe the client for inadequate oxygenation and tissue perfusion, perform and interpret our vital signs, including our O2 saturations and our pain levels. Also assessing lung sounds, making sure we have good breath sounds in all lobes. Assessing for active bleeding, both internally and externally. So internally, again, you're going to look for changes in mentation status if you have a bleed in the heart, or maybe you have a bleed in the abdomen. We're going to be looking for a distended abdomen becoming firm with a lot of discomfort. Also, make sure that you look at your lab. We want to interpret our lab to see if it's within normal limits, out of normal range. Ask ourselves, what does that mean for our patient? And make sure we are trending our lab to identify ups and downs. Any of our patient that has alteration in tissue perfusion, cardiac output, we need to make sure that we are applying oxygen on our patient. Position our client in the proper position. If it happens to be a patient who's short of breath, of course, we're going to elevate the head of the bed. If a patient's whose blood pressure is dropping, we're going to drop the head of the bed. We need to call rapid response team, get a little bit of help in there, have a second pair of eyes on your patient so that they can help you decide what you need to do, maybe what is going on with that patient. We need to ensure placement of venous access. So our IV lines need to be large bore lines if possible, making sure that they are patent, and then altering IV fluid infusion rates according to our patient needs. Diagnostic tests, especially our lab tests, will have enzymes that are released from damaged cells and circulate in the blood that can be measured to help confirm impaired perfusion. Creatinine kinase, or CK, is one of the tests that we look at. There are 3 different ones, though, that you need to be aware of. CKMB is present in the myocardium, CKBB is present in the brain, and CKMM is present in the muscle. So depending on what tissue impairment we have, we'll be looking at a different type of creatinine kinase. Another test is lactate dehydrogenase, which is also known as LDH. This is an enzyme that is found in large amounts in the heart, liver muscles, and erythrocytes. LDH1 is an isoenzyme that is elevated after damage to the myocardium and the erythrocytes. So that's a specific test we might look at. Troponin is also another one. It is a myocardial muscle protein that is released after myocardial injury. So if we see elevations in our troponin levels, it is associated with a myocardial infarction. It is a predictor of future cardiac events also. Homeocysteine levels is an ammonia acid produced during protein metabolism. It promotes atherosclerosis, so not a good thing. This is hereditary issue. Elevations are known with vitamin deficiencies such as vitamin B6, 12, or folate. It is a predictor of coronary artery disease, cerebral vascular disease, peripheral artery disease, and also venous thrombosis. C-reactive protein, or CRP, is a protein produced by the liver during acute inflammation. It is a risk factor for coronary artery disease and is a predictor of future cardiac events with unstable angina and MI. Other tests include serum lipids, which help detect hyperlipidemia, cholesterol, lipoproteins, looking at HDL or good lipids, LDL, which are not our good lipids, and also triglycerides. So they provide information about risk factors and possible presence of vessel disease. Naturetic peptides include two hormones. We have an atrial natriuretic peptide, or ANP, which is secreted from right atrial cells when right atrial pressures are increased, and this is due to detect heart failure. The other thing is also brain-type natriuretic peptide, or BNP. This is a hormone secreted from the cardiac cells and are increased in large amounts when pressures are high to detect heart failure. We've already had our skills lab and EKG or ECGs, and this is a 12-lead placement on the patient's chest to record electrical impulses through the heart. It detects dysrhythmias, it detects myocardial ischemia or infarction, and again, remember our ST segments. If we see elevations in those, we are concerned with current heart attacks. Cardiac stress tests can be exercise or pharmacological. Exercise stress tests are non-invasive with the use of treadmill and progressive increase in speed and elevation while a patient is walking on the treadmill. We would monitor EKG, blood pressure, respiratory rate, noticing if the patient is symptomatic at all. That would indicate that there is coronary issues going on. Pharmacological, we would use a specific pharmacological agent that stimulates physiological effects of exercise. For some radiographic studies, chest x-ray, especially looking at, if there are any lung issues, but looking at the heart size, making sure it is appropriate shape and within the normal border limits. Also doing ultrasounds, not only of the heart, but also of the different vessels and arteriograms that allows visualization of arteries by injecting a dye into a specific area to identify location and extent of any occlusion that might be present. Cardiac catheterization allows a visualization of the coronary arteries and also the heart chambers. Clinical management associated with the concept of perfusion include prevention and also early detection. So the role of the nurse as an educator is huge in making sure that our patients stay healthy with good tissue perfusion. Primary prevention, of course, is the key. Measures to promote health and prevent development of disease. So we want a heart-healthy lifestyle. We're looking at heart-healthy diets, so fresh fruits and vegetables, grains and legumes, fat-free or low-fat dairy products, making sure that we eat lean meats, fish and poultry, staying on low-sodium foods, not using salt through our meals, and then also reducing saturated and trans fat to less than 10% of our total calories. Daily exercise is also important. We should be getting at least 30 minutes a day for 5 days at an average of a moderate intensity of activity. And then, of course, children need to have a higher level of minutes a day. Secondary prevention includes screening. So blood pressure every 2 years or yearly if elevated, checking lipid levels, men 35 years and older, anyone that has an increased risk of 20 to 35 years old, women 45 years and older, and an increased risk of 40 to 45 years old. So also we have early diagnosis. We want to make sure that we're doing visits with our provider, and then remembering prompt treatment of existing health problems is important. Collaborative or tertiary prevention is the management of individuals with impaired perfusion being dependent on a specific condition. We're looking at nutrition, again, lowering lipid levels, losing weight if needed, activity, whether it's weight loss, cardiac rehabilitation, progressive activity to tolerance, position of lower extremities. If we have a patient that has arterial occlusions, being in the dependent position or elevating extremities for a patient that has venous problems or venous occlusions, smoking cessation and teaching our patients about that, and then teaching them about their medications. And this shouldn't be anything new to you, but maintaining a blood pressure less than 120/80, cholesterol levels less than 200, blood glucose levels less than 100, and then achieve and maintain desirable weight for our patients. So several diets that we're going to look at for heart healthy include the DASH diet, the dietary approaches to stop hypertension, effective in lowering systolic and diastolic blood pressure and LDL cholesterol. So this diet includes rich in fruit, vegetables, low-fat dairy products and whole grains, moderate amount of poultry, fish, and nuts, and low in fat, red meats, and added sugar. And we need to note that this is rich in potassium, magnesium, calcium, and fiber, and also low in total fat, saturated fat, and cholesterol. Another diet is a TLC diet, or the Therapeutic Lifestyle Changes diet. This you can find in your nutrition book, DUDAC, but what this does is mainly focuses on health issues such as diabetes, obesity, anemia, etc., and it is a diet that is focused specifically on that health issue. Other diets include iron-rich, vitamin B12, and folic acid. So things that are high in iron include beef and pork liver, soybeans and lentil, clams or shellfish, and spinach. Vitamin B12 include meat, fish, poultry, eggs, milk products, and then fortified cereal. And then folic acids are found in dark green vegetables, carrots, and lentils. Pharmacotherapy for perfusion issues include vasodilators, vasopressors, inotropic agents, antiarrhythmics, adrenergic agonists, anticoagulants, thrombolytic medications, and then cancer chemotherapy targeted drugs. And again, just depending on what the issue is, will depend on which type of medication is used. Vasodilators, what do they do and what are they for? They increase the diameter of blood vessels, causing a decrease in vascular resistance and an increase in blood flow, used for angina, hypertension, and CHF, or congestive heart failure. Examples of vasodilators include nitroglycerin, angiotensin receptor blockers, or ARBs, the sartans, angiotensin II inhibitors, the IDEs, angiotensin converting enzyme inhibitors or ACE inhibitors, the PRILs, beta blockers, LOLs, and the calcium channel blockers, the DPINs. Just a little reminder, angiotensins increase aldosterone concentration, causing sodium retention and vasoconstriction. Thereby, these medications inhibit that, so we're going to see the opposite effect. Vasopressors, what do they do and what are they used for? Vasopressors decrease the diameter of blood vessels by stimulating the alpha adrenergic or dopamine receptors to affect the normal mechanisms of vasoconstriction, an antidiuretic hormone that acts on the kidneys and blood vessels. It is used for hypotension, VFib, VTAC, and asystole. Included in this category are epinephrine and dobutamine. Inotropic agents are categorized as positive or negative. Positive inotropes stimulate and increase the force of contraction of the heart muscle, used for low cardiac output or cardiogenic shock. Negative inotropes weaken the force of a muscle contraction, decreasing the workload of the heart. Examples of inotropic agents include our positive agents are dobutamine, milorone, digoxin, and dobutamine. Our negative inotropes are our beta blockers and our calcium channel blockers. Antiarrhythmics, they correct erratic electrical impulses to create a regular cardiac rhythm by blocking electrolytes that affect electrical conduction of the heart. Again, they are used for dysrhythmias. So some examples of dysrhythmias can include our beta blockers, or our LOLs, our calcium channel blockers, our DPINs, adenosine, and again, when we're looking at this, it just depends on what the dysrhythmia is. So a beta blocker would convert SVT and VTAC to a normal sinus rhythm because it slows the heart rate and decreases the blood pressure. A calcium channel blocker would control irregular heartbeat and slows the heart rate, decreasing the blood pressure, and that's used for SVT, atrial tachycardia, atrial fib, atrial flutter, and VTAC. And then adenosine converts SVT to normal sinus rhythm because it slows the conduction. Adrenergic agonists, what do they do and what are they used for? They are medications that mimic the effect of sympathetic activation on the heart and circulation. In other words, they're stimulants to the heart. They're used to treat cardiac arrest and shock. And some of the different types include bronchodilators and vasopressors. A couple of common vasopressors include epinephrine and dopamine. We talked about anticoagulants and why they're important to our heart health, because they prevent blood clot at several locations in the clotting cascade to suppress the production of fibrin. It is used for the prevention of venous thrombosis. So again, we're trying to prevent blood clots that can cause heart attacks and other problems. You should be able to identify these anticoagulants: enoxaparin, heparin, and warfarin, and notice the ending on these, how similar they are. Our thrombolytics are medications that disrupt blood clots that are impairing perfusion by lysing fibrin. So this is used for thrombolytic stroke and PE, or pulmonary embolism. Examples of our thrombolytics include those that end in the ASE: alteplase, streptokinase, urokinase, and cathflow activase. Cancer chemotherapy targeted drugs. What do they do and what are they used for? Drugs used for chemotherapy exert their cell-damaging or cytotoxic effects against cancer cells, and remember, they also are damaging to the healthy cells. So we need to focus on what these drugs do, not what they are. So remember, they suppress the effects on the bone marrow. So we can have problems with anemia because of decreased number of red blood cells and hemoglobin. neutropenia because of decreased number of white blood cells, and thrombocytopenia because of decreased number of platelets. So I want you to think about potential side effects of these medications. As you review what their action is, you also need to think about what problems can occur from that. So we've got vasodilators that are used to dilate the vessels. Therefore, we want a blood pressure maybe to come down, but we can also bottom a blood pressure out. So I want you to be thinking about that as you look at each one of these particular medications and what they're used for and how their action. Your nursing actions associated with any kind of medication administration of the heart, you need to think about assess, assess, assess. You have to have a baseline assessment. You need to do focused assessments throughout your shift, and especially look at your heart rate, your blood pressure, your O2 sats, EKGs, your lab, and any other diagnostic that can be affected by this medication. Procedures and surgical interventions to treat perfusion problems are going to be identified in our collaborative learning assignments. So our student groups that are putting PowerPoints together are going to be identifying pacemakers, electrical cardioversions, intra-aortic balloon pumps, heart valve surgeries, cardiac transplant, coronary artery bypass graft, peripheral artery revascularization, stent placement and angioplasty, and possibly endarterectomy. So just make sure that you look over these PowerPoints. We will present them in class, but they will also be information that you need to be looking at. We're going to look at some cultural, legal, and ethical issues. Remember, these include things like our full code, our do not resuscitate, our do not intubate, things that the patient has requested. Maybe we have patients that are of a religious belief, such as Jehovah's Witness, that does not accept blood transfusions, yet might need them for a life-saving heart issues, or maybe family dynamics in which there's family issues. One person wants to save the life and the other person wants to let that person die peacefully. So I just want you to be thinking about these different types of issues as you go into your ICU units and when you see different types of cardiovascular issues. So we've touched base on tissue perfusion, or perfusion in particular, and how it is related to our cardiovascular issues. I want you to think about all of the interrelated concepts that have been touched on with perfusion. They include pain, inflammation, elimination, cognition, mobility, nutrition, acid-base imbalances, shock, fluid and electrolyte imbalances, gas exchange, clotting, and also patient education. All of these are interrelated with our perfusion concept today. And as always, don't forget to look at your NCLEX RN test plan blueprint. Have a great day.